everybody to the fourth PACES Advancing the Field Conference, Clinical Conundrums in Inherited Arrhythmias. As this is the fourth of these Advancing the Field conferences, I just wanted to kind of go through some of the ground rules, or basically the purpose of this meeting. And the Advancing the Field meeting was founded on the idea of it's a forum to foster an exchange of innovative ideas and high quality collaborative research to allow attendees to draw on the experiences of leaders and innovators and to continually advance the field of pediatric and adult congenital EP. Now, as many of you know, this meeting has grown quite a bit, and so only about a third of our attendees today are actually electrophysiologists. It's grown to where general cardiologists, allied health professionals, and even genetic counselors and even families will be on the meeting today. However, we still want the idea of the meeting to be the same. We want it to be a forum to foster collaborative ideas. We want everyone to feel welcome to ask questions, and hopefully everyone can do that through the HOVA app. And we want everyone to go away learning something and hopefully having a good time. Now, it's truly an international conference. We have faculty from all over the globe, including Australia, Canada, and the United States. But more importantly, we have attendees from all over the globe as well, too. And when I looked at the attendees list just this morning, we have people joining us from South Africa, Turkey, Bogota, Hong Kong, Finland, Italy, England, and other parts of Europe. And then, of course, the United States and Canada. So this is truly an international group, and we want to thank everybody for taking the time to be involved in this meeting, and hopefully you'll go away learning something. Now, this meeting is co-sponsored by the Sudden Arrhythmic Death Syndromes Foundation, and that foundation is a great group that advocates for patients and advocates also for the exchange of ideas and for learning. And so I'd like to hand over the introduction to Alice Laura of the SADS Foundation.
Hi, thanks, Tony. And we are so excited to have everybody, like you said, from all over the world with us today attending this conference. I'm really excited and happy to partner with PACES and to share the WOVA app with you. We had a family conference a month ago and used this app. So hopefully it will work. We really are excited about this conference. I really wanted to just give you a brief introduction about the SADS Foundation because we have so many folks that might not be familiar with us. But as Tony said, we are really the leading organization for patients and families who are genetically predisposed to sudden death due to heart rhythm abnormalities. And it's our mission to support them, to help save lives of patients and families by awareness, by support, and by, as Tony said, really facilitating medical education and research and anything that we can do to make sure that our folks get the best care possible. And because of that, the number one thing that I think we would ask of you and that we can provide for you is to get you to be referring your patients to us for that support, for the information that we have about the SADS conditions, specifically for families, and all the other information that we have for families to use, for instance, with their children's schools, helping get an AED for their home use, all the things that they need in their daily life we can help with, as well as meeting with other families and talking about their feelings, etc., is really helpful to meet someone else. And then finally, the last two things I'd like you to know in terms of our many programs, and that is that we do have a program specifically for geared towards physicians, and that is the chance to submit a challenging case to us that would go out to our International Scientific Advisory Council. And provide you with information, with ideas, with suggestions potentially for your particular patient that you have questions on. So that's really helpful and has done some amazing things for individual patients in the past. And then we also would offer a physician referral network. So if you're interested in getting involved, particularly in the US, we do refer patients to our physician referral physicians. So we're happy to be involved with that. And then lastly, we'd love to have you connect with us, get our e-newsletters, attend other seminars, and you can find that information on our website at stopsads.org. And thank you again. And I guess I turn it over to Carolina now.
Yes, so thank you to everyone for joining us today. I'm going to review some of the housekeeping for today's session. You will all be watching the session via the HOVA app, and through this app, that's where you can ask questions to the speakers from our sessions today. The questions that you ask are specific to the speaker or to the session. Each talk will be 10 to 15 minutes in length, with then 5 minutes for questions at the end of the talk. You can upvote the questions in the app for the questions that you would like answered the most. If we don't have time for all of the questions during the question periods for the session, we will try to address some of them during the panel discussion, which is the last session for today. In order to attend the next talk, you will need to click on the link in the agenda in the HOVA app. So please click each of these links to progress to the next session. As I mentioned, the last session today will be the panel discussion. The panelists will need to switch between different session links, so it may take a few moments between our last speaker's talk and starting the panel session, so please be patient with us if there is a delay. And if there is a delay, then the final panel discussion may extend for a few minutes past the scheduled time. So it is now my pleasure to introduce Dr. Michael Ackerman, who is going to be providing the keynote lecture today. Dr. Ackerman is a professor of medicine, pediatrics, and pharmacology at the Mayo Clinic in Rochester, Minnesota, and is the director of the Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic. He's internationally recognized for his extensive work in clinical and translational research efforts in the field of heritable cardiovascular disorders, genomics, and genotype-phenotype relationships in heritable cardiovascular diseases predisposing to sudden death. He will be speaking to us today about upper limit of normal versus disease. How do I rule out long QT syndrome in borderline cases?
Well, Dr. Escudero and everyone, can you see me? Can you hear me?
Yes.
And can you see my slide?
Yes, we can.
Well, congratulations to you all, and thanks for doing this. I am about ready to set my timer. Oh, we're not even live, are we? We are actually virtual. So masks off, but don't forget, I mask, you mask, we all mask together. I'm thankful to be the keynote. You can set your timer now. Mine's 15 minutes, and I hit the start button now for my assigned time. I'm just the warm-up act for everybody else, and we're gonna take 15 minutes to unpack this borderline case issue, which really is about QT confidence and competence, getting it just right. I'm conflicted. These are my relationships with industry to disclose. I don't think they're going to affect our ability adversely or negatively to do this, to assemble skills, to reveal some pearls, and identify the cutoff values that will warrant further investigation to really make you QT competent, QT confident, with navigating the borderline issues. Sometimes it's easy, isn't it? This is obvious long QT syndrome, nothing borderline here, must be extreme QT prolongation, therefore obvious long QT syndrome, a 1 in 2,000 condition for which some of us are well acquainted with, but not so fast. The owner of this ECG doesn't have long QT syndrome at all, just has a little too much cesium toxicity. So remember, extreme QT prolongation does not equal congenital long QT syndrome, even when the QT interval isn't borderline at all. Now, instead, it's going to be drugs or electrolyte abnormalities that give us extreme QT prolongation. So don't get fooled. Don't immediately think long QT syndrome. Remember, the QT drug hit list website can be incredibly helpful for your practices. How about this one? Nothing borderline here. This is called L normal, isn't it? It's as normal as they get. So borderline case, borderline difficult? No, not abnormal at all. But this patient absolutely owns a long QT causative mutation, no doubt about it. And it serves as a vivid reminder that we have to do mutation-specific genetic testing when we have long QT established. A normal ECG in a family with long QT syndrome cannot rule out long QT syndrome. Only the genetic test can. Well, how about here? We're going to really delve into this, the QTC value, borderline. You've heard that expression. That's where the expression of borderline cases come from. So maybe a borderline length of repolarization, but is this a borderline look of repolarization? Not at all. In fact, it is the length and the look of repolarization that prompted the great Peter Schwartz to once say, Michael, I don't measure the QT interval, I look at it. And so there are looks of repolarization that can take a borderline length and maybe tip off the presence of a not so borderline long QT syndrome, an obvious case, such as these genotype specific looks of repolarization. So we got to figure out how to get it just right. And can we rely on the computer in these cases? Well, remember this one from just 3 minutes ago? Extreme QT prolongation, not congenital long QT syndrome, but also extremely missed by our ECG reading room, to which I like to say that the computer-derived QTC is accurate, plus minus 400 milliseconds. Now, it turns out that it's actually quite good overall. And in fact, Sammy Viskin has taught us a sobering message that the QT by the computer is actually better than we are. And the goal of the next few minutes is to help make all of you joining us to be better than the heart rhythm specialists and the 3/4 of cardiologists who got the QT wrong. Why is this really important with respect to the borderline cases? Well, this is now an old study, 13 years old, where this was the profile of 176 consecutive patients who came with a referral diagnosis of long QT syndrome by a heart rhythm specialist, both pediatric and adult. And when they came through our program, definite in a quarter, possible in a third, but look at this, fully 40%, we said, not so fast. And in this context, genetic testing will be extremely helpful for you, because when we said it was clinically definite, we got a positive test result in 75%, 38% when I said possible. And when I said no way, not there, not feeling it, the genetic test was negative. Important point, if the genetic test comes back negative and you're still going to call your patient long QT syndrome, timeout. Take a really close look at the strength of the clinical evidence. Back then and still now, 40% of the patients that came to Mayo Clinic with the diagnosis of long QT left without it. The two most common errors, sins of commission, if you will, is overscribing a wimpy story, a vasovagal faint, getting a borderline QT interval, and then moving them to long QT syndrome. We need to stop that. The other is egregious QT interpretations like this ECG from one of those. Completely normal, but you can see what somebody underlined and marked right there, for which they said the QTC is not normal, it's actually very prolonged. And so we had to both undo this mistake and remove the patient's defibrillator that was implanted for an overdiagnosis of long QT syndrome. So how do we get the QT just right in these cases, whether it's borderline or not? We need to go back to the basics. We need to do what Arthur Wildes said, teach the tangent or avoid the tail. And when you and I are confirming the veracity of the computer's quantitation, we need to do this. Go down the isoelectric, take the isoelectric segment, go down the downslope, and intersect it there, and resist the urge to do the sin of QT inflation by U wave inclusion. And then when you've done that, and I give you these next 5 things, you're going to be a lot better than the 3/4 of cardiologists and even the 1/3 of heart rhythm specialists who are QT challenged out there. And those 5 things are: first, use lead 2 and V5 for your QT confirmation leads. Stay away from V2 and V3. Go down to V5, look at there, put your eye or your calipers in the QT interval and sensor it there, and then look, and if your QT interval matches the computer's, you're done. You verified the QTC because the computer can do RR really well. On the fly, if you can see that the QT is less than half the RR interval, the QTC will always be less than 460. That doesn't rule out long QT syndrome. It just tells you quickly that you're under 460. Be careful in sinus arrhythmia. Don't take the maximum QT and the minimum RR. That will grossly overestimate the QTC. Take the average. And then remember that the patient's QTC truth will break down at slow heart rates. You're going to underestimate the truth, and it'll overestimate at high heart rates. But one of the things I see way too often in pediatric heart rhythm programs is somebody with a QT of 500, heart rate of 50, getting called prolonged QTC because they're just stating the absolute QT. That's not going to be good. That's going to swing it in the other direction, and we'll illustrate that. Bonus is the wide QRS adjustment, for which you then normalize it as if the QRS or depolarization was normal. An extra bonus: patients with congenital long QT syndrome almost never have a wide QRS. And so that can help you. And then if you take these and you can censor the QTC better, which one are you going to act on? What level bothers you? And this is really important to get this right, and we haven't understood very well the distribution of QTC in health and disease. This is the average of our entire program. And when it's way out there in genetic long QT, high risk, of course, almost never seen. 600, almost never seen. Lines in the sand for risk at 530, but the best line in the sand, never forget, never disrespect, is the QTC 500 millisecond line. You may have stumbled into long QT syndrome incidentally, and if they have genetic long QT syndrome, it's not a borderline case. It's an at-risk case. But here's the dilemma of QTC values in our long QT patients that had normal and can be really normal, like as normal as they come on the left. And then juxtapose that is where the official word borderline came from, the 440 line. And borderline QT prolongation has gotten incorrectly translated to borderline long QT syndrome way too quickly, because that's a lot of people. Now, replacing borderline is the 450 line for men, 460 line for women that satisfies a guideline definition of prolonged QTC. But if there's no story, no nothing, almost never going to be long QT syndrome. So nothing borderline about that case. So how do I do it? Remember these lines in the sand: 480 women, 470 men, and 460 before puberty. And act on those lines. These don't equal long QT syndrome. They equal about a 10% chance of having come upon long QT syndrome. So if your index of suspicion is story driven, you don't like the story, you don't like the ECG, you don't like the treadmill stress test, they get the full court press, they get the drill. And so we have to come back to the story. Are you bothered by the story? Does that faint bother you? Does that seizure bother you? Does the timing of that spell with the auditory trigger bother you? And if yes, we're not dealing with a borderline case, we're dealing with the possibility, the real possibility of long QT, for which we must do long QT genetic testing. On the other hand, no story, incidental loma, and their QTC is below those cut points, get out of that situation, dismiss them. Don't call them borderline, dismiss them. Now, if they exceed those cut points, 480 women, 470 men, 460 before puberty, do a bit of a drill. the best, repeat the ECG, get an ECG on the parents. And if those follow-up tests fall below those cut points, get out of there. Dismiss them. Don't call them long QT syndrome. But if they exceed that in any of them, commence the drill. And again, the drill is going to include the genetic test. It's a guideline recommendation. It has been for 9 years to get genetic testing. Never disrespect the 500 line. You may have stumbled into it, long QT syndrome, if there's no story, and you cannot blame it away on drugs. If there is no exogenous acquired factors, you now have a greater than 50% chance that you have stumbled into long QT syndrome. So even if asymptomatic, get the genetic test. And again, if the genetic test comes back negative, the story better be really good, because by itself, the genetic test rules out 80% of all congenital long QT syndrome. So I mentioned it once, I'll mention it again. Do not disrespect the QTC 500 millisecond line. Now, 2 minutes on my counter, and I leave you with something that's an incredibly useful free resource that was born out of the COVID-19 pandemic, and that is our online QTC calculator by the chief architect, Alan Sugru. So use this, go to this website. It can help you a lot. It can teach you a lot. So when you go to the website, you can go to the calculator and type it in, and you can look at your patient. Your patient is 12 years old, and you measured by those tools 500. And then you see here that the heart rate was 50, and you type in 50, and you say, wait a second, not so fast, 456. Don't use 500 there. But now the heart rate was 90, and now you're dealing with that for the QTC. Now, if the QT was 450, and now you have a QTC. So this can help you tremendously. Take advantage of this resource after you've applied it to the QT measurement that you made. So I leave you with a counter at 1 minute. These 5 take-home points. First, extreme QT prolongation does not equal long QT syndrome. Second, normal QTC values do not rule out long QT syndrome, especially the families. Only the negative genetic test result can get you out of that borderline case. Third, there might be a borderline length, but there's not anything borderline about the look. Remember, not only the length of repolarization, but the look of repolarization. Fourth, avoid those tails. Do not commit the sin of QTC inflation and subsequent long QT overdiagnosis because of that U-wave inclusion. And then last, if that long QT genetic test is negative, that story and that ECG better be very compelling. So I have 5 seconds to thank these entities for partnering with our program to help us heal the sick and advance the science. And I would love to have you join us next in 10 months in Vanderbilt if you want a little bit more, a lot of it more, on the genetics of heart and vascular disease. So I'd love to see you questions you have. Thanks for having me. And then I'll be back again after these 5 minutes in the full speaker powwow with all of you. Thanks, everyone.
Thank you very much, Dr. Ackerman. That was an excellent talk. I don't see any questions right now on the Whova app, so anyone who's watching, please feel free to put in any questions, which we will ask the speakers at the end of their talks. So perhaps I'll just ask you something. In terms of trying to rule out long QT syndrome, how do you use the exercise test? What sort of values do you use, and what timing do you look at repolarization during recovery?
Well, I think there's a couple things there, Carolina. First, the exercise stress test is really an LQT1 challenge. So it's a great test to unmask concealed LQT1, and there the money is in the recovery phase, where a QTC greater than 470 milliseconds at 3 minutes of recovery, 4 minutes of recovery, doesn't really matter which, both are equally predictive, has about a 70% positive predictive value that you have unmasked LQT1. So I think the stress test is very good for that. It's reasonable for LQT2 because you have so-called QTC latency that emerges with a difference between the recovery QTC at 5 minutes and versus the one at 1 minute. The other part where the stress test is helpful, obviously, is monitoring your satisfaction with your level of beta blockade. But I think people have forgotten that the stress test really is, at its best, an LQT1 challenge assessment. It doesn't rule out all long QT syndrome, for example, but it's a great great test to unmask concealed LQT1.
All right, Mike, I received another question that asked if you don't pay attention to the raw QT on a bradycardic patient, how do you interpret the QT or the QTC in those patients?
Yeah, I think the biggest thing there, Tony, is that I've seen, I can't tell you how many times where the QT was 500, the heart rate was 45, 50. So the QTC would measure by Bazette, say 440. And instead of reporting the 440, they report the 500 absolute QT as the QTC. When instead the QTC truth in that setting of bradycardia is going to be somewhere between the Bazette's underestimate 440 and the raw QT. So the raw QT will overdiagnose big time. The Bazette's will miss a few. So what I do then is I'm aware of that. I think about that. And then I say to myself, okay, what am I going to get in their QTC when I have them on a stress test? And now I'm in the first minutes of the stress test when their QTC is moved from 45 to 65, 70, where the performance characteristics of Bazette's is better. And then see what happens to the QTC number. Is it similar to at the bradycardia, or did it become very different? And so I think the biggest appeal I would have to the pediatric cardiology and the pediatric heart rhythm community is don't report out the absolute QT in the setting of bradycardia as if that's a closer approximation of QTC truth. You just swung the pendulum exactly in the wrong direction towards overdiagnosis when you've done that. Just keep it in mind, see what happens to the QTC when the heart rate moves. Even in the office, you could just have them walk around to get the heart rate out of the 45 zone and into the 60, 65 zone and remeasure their ECG and things like that.
Great. Thank you.
Yes, thank you very much. There are a couple other questions that have come up, but I think for the sake of time, we will save those until the panel discussion. So for now, for going to the next session, for those of you in the Whova app, please remember to click on the link in the agenda.
Okay, see you all in a little bit. Thanks, everyone.
Okay, for the physicians breakout session, I would like to introduce Dr. Elizabeth Sherwin. Dr. Sherwin graduated from Virginia Commonwealth University for her medical degree. She did residency, fellowship in cardiology, and also fellowship in electrophysiology at Children's Hospital Boston. She served as the director of electrophysiology at British Columbia Children's Hospital in Vancouver. And then she returned home to the greater DC area, where she now is on faculty at Children's National Medical Center in Washington, DC. Again, I'd like to welcome Dr. Sherwin, and her title of her talk is Phenotype Resuscitated Sudden Cardiac Arrest, What to Do When You Have No Other Signs.
Thank you so much, Tony. It's hard to follow Dr. Ackerman. Please jump in if you don't hear me or can't see my slides, but I'm going to push forward in the interest of time, 10 minutes for a big topic. But it's great to be here with everybody, if not only virtually. In the next 10 minutes, we're going to talk about what to do with a resuscitated sudden cardiac arrest patient who has no phenotype. What to do when there's no other signs. My only conflict of interest is not relevant to today's talk. So sudden cardiac arrest or aborted sudden cardiac death is rare, but it's very memorable. It's frightening and it's really challenging, sometimes medically, of course, and also emotionally for the staff and the families. Our goal after the medical stabilization occurs is to elucidate the etiology of the rest. What is the underlying diagnosis? Why did this patient have this? To prevent recurrence in that patient, of course, and to also screen the family to evaluate for other at-risk individuals and prevent further cardiac events. If there's no clear hemodynamic, structural, or cardiac functional condition found, then we often term that SADS, or the sudden arrhythmic death syndromes. These are primary electrical conditions. When I think of what causes a teen or young person to collapse suddenly and have a cardiac arrest, I think of three general buckets: the anatomical issues such as cardiomyopathies or congenital heart disease, electrical issues such as Wolff-Parkinson-White with pre-excited atrial fibrillation, polymorphic ventricular tachycardia or torsade de pointe, and ventricular fibrillation. And of course, the other things, acquired conditions like myocarditis, pulmonary hypertension is another congenital disorder. Coronary artery disease, though rare, can happen in young individuals with familial hypercholesterolemia, and commotio cordis and non-cardiac issues. So once there's been a sudden cardiac arrest and a patient is admitted, how do we make the diagnosis? Well, typically we're looking for the phenotype. We know the event, the arrhythmia, if it was documented at the time of the presentation, but what is their phenotype? What's underlying that background? The phenotype, of course, is a set of observable characteristics or traits of an individual resulting from the interaction of their genotype or DNA with the environment. This can be physical characteristics, behavior, clinical findings. And of course, our bread and butter when there's a new patient admitted is an EKG and imaging with an echocardiogram. Though we never want to find this, sometimes the EKG and the echocardiogram can give us a very clear answer with very clear history and guidance on management options. Sometimes the EKG alone can give it away. For example, in this 12-lead electrocardiogram, this is sinus rhythm with Wolff-Parkinson-White or pre-excitation. And of course, these patients are at risk for pre-excited atrial fibrillation, which can degenerate to VF and result in hemodynamic collapse. Thankfully, ablation is curative. So there's always a little bit of me that crosses my fingers when there's a new arrest patient that it could be WPW with a simple ablation to treat them. Other times, the EKG gives us clues for one of the inherited arrhythmia conditions. This is a patient with long QT type 3. He presented with sinus bradycardia, very abnormal T-wave morphology, which is the most striking. And as Dr. Ackerman pointed out just now, his raw QT was 496, which doesn't tell us an entire story, but the corrected QT was low or normal at 450 for this post-pubertal male. However, the look of the T-wave is the most striking and the most suspicious for this young man. But what if our EKG and our echo are normal? There's no phenotype other than the presenting event. Then what? Well, we keep looking, of course. That's only the top of the, scratching the surface of our diagnostic capabilities. And when we don't see anything obvious by echocardiogram or WPW, then we're thinking more of the inherited arrhythmia syndromes. Primarily the ion channelopathies, and I include arrhythmogenic right ventricular cardiomyopathy in this category, as the electrical abnormalities can precede the myopathic changes that are visible on gross testing, and therefore they may present with a relatively normal looking echo, but arrhythmias. So here's an example of a 14-year-old young man who was had a history of attention deficit hyperactivity disorder and fetal alcohol syndrome. He was at school one day when he felt lightheaded during recess, and as teenagers tend to do, apparently thought it was a good idea to drink a Monster energy drink. While standing in class shortly thereafter, he had loss of consciousness and a cardiac arrest. Thankfully, his school had an AED, applied it, and found that he was in polymorphic ventricular tachycardia, and he received 3 shocks with return of circulation. This Monster energy drink was the 3rd patient that I've seen have a cardiac arrest after drinking an energy drink, and their motto of unleashing the beast, I think, is very appropriate. It certainly did that for this young man. So of course, beyond the EKG and the echo, we want to know history. The history is so critical. Does that patient have any past history? Have they had any past symptoms? Even if this is their first time being presenting for care, they often have previous symptoms that were not discovered or evaluated. And of course, the prodrome, the context, the family history. In many cases, we may not be able to ask the patient this if they're unconscious, and or the family may not be present or have witnessed the arrest. So then we go to our menu of options for our diagnostic evaluation, far beyond a basic EKG and imaging. From an electrical evaluation, we can do simple tests to signal average ECG, available in many centers, that's primarily looking for arrhythmogenic cardiomyopathy. High-lead EKG by moving up the leads to the second intercostal space to bring out a Brugada pattern that might not be seen at baseline. And here I'm really talking about the acute presentation and evaluation after an arrest, not an outpatient relative. Beyond the echocardiogram, a cardiac MRI or CT scan can provide additional 3D imaging for function and anatomical definition. And occasionally we might consider a cardiac catheterization with angiography if the coronary arteries are not well seen or there's other questions. From a provocative standpoint, this is where the electrophysiology really gets to be better evaluated, with some tests to try to bring out changes. A resting electrocardiogram is not present or is not the entire story and may not show the entire patient's history or phenotype. So an exercise stress test is certainly one of our best if the patient is ambulatory and able to, after a cardiac arrest, to look at QT dynamics and inducible ectopy or arrhythmias. Procainamide challenges and other sodium channel blocker challenges can also be done for Brugada, epinephrine challenges to try to bring out long QT or evidence of CPVT, and occasionally, though less frequently, an EP study for ventricular stimulation and pacing. Have to, of course, talk about genetic testing. That is worth mentioning because oftentimes the clinical bedside team wants to go straight to genetic testing, but it's worthy of thought and pause. Just last month, the Heart Rhythm Society and Asian Pacific HRS published this expert consensus on genetic testing and other evaluations. And they note very appropriately that focused genetic testing can help with the diagnosis, but it really requires thoughtful consideration because it could be misleading and more confusing. But if there's no suspected phenotype, with appropriate genetic counseling, we can do targeted genetic testing for arrhythmia conditions. And that's here a class 2A for a young individual with an unexplained cardiac arrest. So while we wait for the genetic testing, because of course we won't have that back for several weeks, now what do we do? Well, at this point, I would presume a diagnosis of either idiopathic ventricular fibrillation, a diagnosis of exclusion, or concealed arrhythmia, inherited arrhythmia syndromes, where their phenotype is just not evident at that initial evaluation. So of course, we move forward and we treat them to protect them. An ICD, secondary prevention ICD after cardiac arrest is very standard as long as they meet other criteria with expected survival of a year, etc. I would advocate for beta blocker therapy. There's not a lot of evidence for this, not a lot of data in this particular situation, a pediatric patient with a phenotypically negative cardiac arrest. However, there's very little downside. We know that other medications, amiodarone, quinidine, beta blockers in other situations like heart failure have been shown to be beneficial. I think that the downside is low. And so I typically, if there's no contraindication, I would start a beta blocker to reduce the risk of a recurrent ventricular arrhythmia. And of course, I follow lifestyle interventions as if they had a confirmed diagnosis of long QT or Brugada, for example, by encouraging excellent hydration, reporting and paying attention to symptoms, avoiding QT prolonging medications when possible, treating fevers like Brugada syndrome, and avoiding substances that may provoke an arrhythmia. Looking in the literature for evidence on this, it's few and far between for this particular secondary prevention for an unclear etiology of a cardiac arrest. But back in the 90s, Dr. Silka and all showed that for secondary prevention ICD, survivors of cardiac arrest did use their ICDs appropriately. Among all comers, here circled in red, the idiopathic ventricular fibrillation were less likely to use their ICD again, but other conditions certainly did. When I look for evidence to support what medication is going to be most efficacious, how often do patients use their ICD in these phenotype negative pediatric arrest patients? It's a lot of crickets. I think this is an excellent area for future research and is an ongoing project of collecting information on pediatric cardiac arrests. Family screening is critical, of course. Just to touch very briefly, it's not only logical, as many of these conditions may be inherited, but it's fruitful. Among adult survivors of cardiac arrest from the CASPER study, 17% had confirmed diagnoses of arrhythmia conditions. In this pediatric study by Guiducci and al., 13% of families had a pediatric patient or relative identified with an inherited arrhythmia syndrome. The really other critical part of evaluating and managing these patients is their follow-up and reassessment and reassessment. Every time I see the families, I repeat the family history. Have there been any new cardiac events for people? Or happens probably more frequently that they discover an existing family history that they were previously unaware of and their relatives had not shared with them. That can help elucidate the phenotype. I repeat relevant clinical testing as the phenotype can evolve over time. Our EKG is not static. And review genetic testing. If there was originally a variant of uncertain significance, go back, see if that had changed at all. Has it been reclassified in a pathogenic or likely benign direction? And if there was initially negative genetic testing, no variants identified, if 3 to 5 years have passed, we're learning so much more, it's worth discussing the benefits of repeating genetic testing at that time. Very quickly, this study by Mattesini and al. Showed that with their initial young patients with unexplained cardiac arrest, only 50% had a cause diagnosed initially. And during follow-up, 20% had their diagnosis changed, either from an idiopathic VF to a confirmed condition, or one arrhythmia condition to the next as their phenotype changed. So back to our young man, in his recovery in the ICU, he had the testing that was mostly non-invasive and mostly not helpful. No clear phenotype came, though he had some abnormal repolarization. So a long QT panel was sent based on both his EKG and the epinephrine challenge and the adrenergic type of potential setting in which his arrest occurred. He was started on beta blockers and an ICD was implanted. What I didn't share initially, and of course we told him not to drink any more energy drinks, what I didn't share initially was his family history. So here's our proband. His genetic testing ultimately came back with a variant of uncertain significance in SCN5A. His mother had had a cardiac arrest at 33 years of age and unfortunately passed away from cancer 2 years later. He has 2 full siblings. Their grandfather died of a heart attack. And when I hear that word, I always ask clarifying questions because that's a common language used that may not indicate a myocardial infarction, but could have been an arrhythmic event. She had another partner and he had another half brother. And those siblings were tested, 2 of whom had the VUS. And then there's yet another partner who had also died suddenly with additional relatives not yet completed. So in follow-up of greater than 4 years, this young man has never shown a true lung QT phenotype. He's received no shocks from his ICD. And as of today, his VUS remains a variant of uncertain significance. But we push forward and continue to treat. Even when there's no clear diagnosis, we do our best with the secondary prevention ICD. I would advocate for beta blocker therapy, lifestyle precautions, follow-up and reassessment, reconsidering the information, and of course, supporting the family and their mental health. Thank you.
Okay, thank you, Dr. Sherwin. Let's see, we have one question, but I think we'll move forward and we may handle it at the end. So thank you very much. Great presentation.
All right, it is now my pleasure to introduce Dr. Prince Kanankerl to give the next talk. Dr. Kanankerl is a professor of pediatrics at the Vanderbilt University Medical Center with faculty appointments in both the Vanderbilt Genetics Institute and the Vanderbilt Center for Arrhythmia Research and Therapeutics. He serves as the co-director for the Center for Pediatric Precision Medicine at Vanderbilt. His research program investigates genetic variants and their contribution to cardiovascular disease and clinical outcomes. And he will be speaking to us today about RYR2, big gene, too many phenotypes.
Well, thank you for that introduction. And I assume you'll let me know if you can't hear me or can't see my screen. The title of my talk was assigned, RYR2, big gene, too many phenotypes. I certainly agree with the first half of that. RYR2 is a big gene. But I don't think you can ever have too many phenotypes, right? Certainly RYR2 has yet to catch up with SCN5A, another one of my favorite genes. But our story today begins with this plant, which was discovered in the jungles of South America by the Danish botanist Martin Voll in the 1700s. This was a plant with insecticidal properties. And Martin named it after his friend, John Ryan, who sent him many plant samples. And so we call this plant Ryannia speciosa. Now, the insecticidal molecule was identified in the 1940s. And because it came from the Ryannia plant, it was named ryanidine. And now you probably figured out where this is going, right? So the poison ryanidine actually targets the major calcium release channel from the endoplasmic or sarcoplasmic reticulum. And so we named that the ryanidine receptor, or RYR. In nanomolar concentrations, it locks the channel open, and that results in massive muscle contractions. And at micromolar concentrations, it closes the channel, resulting in paralysis. Either way, it's lethal for both insects and mammals, actually. Now, the RYRs are the largest known ion channels to date. They're more than 5,000 amino acids long, each encoded by genes that cover more than 100 exons. In humans, we have 3 isoforms, RYR1, 2, and 3. There's 65% identity in the genes between those 3 isoforms. RYR1 is the predominant form in skeletal muscle. RYR3 is the so-called brain isoform, because if you look in human tissues for RYR3, you see it predominantly in the brain. But actually, when you look at brain, you find more RYR2 than RYR3. RYR2, of course, is expressed in cardiac muscle, but also in the cerebellum and the cerebral cortex, and at lower levels in multiple organs, including the stomach, kidney, adrenal glands, pancreatic beta cells, and others. So it really should be no surprise that there are multiple phenotypes associated with RYR2 mutations. The one we're most familiar with, of course, is CPVT, or catecholaminergic polymorphic ventricular tachycardia. This disease is characterized by a normal heart and a normal ECG at rest, as shown up here. But as these patients exercise, they develop a typical progression of ventricular ectopy, usually starting with single PVCs and then bigeminy and then couplets and then non-sustained, and in this case, sustained bidirectional ventricular tachycardia. And they're also at risk for ventricular fibrillation and sudden death. We've also come to recognize mild sinus bradycardia in many of these patients, as well as atrial arrhythmias. And more recently, we've recognized intellectual disability is fairly frequent, 8%, as documented by the International CPVT Registry led by Arthur Wild and colleagues. Now, slightly more than half of human patients with CPVT have RYR2 variants, and those that have been characterized typically have excessive calcium leak during stress. So some people call that a gain of function. That's not exactly correct, but it's a simple way to state excessive calcium leak during periods of stress. Now, there have been some non-CPVT related arrhythmias associated with RYR2. One of them is this phenomenon here called short-coupled polymorphic VT, or sometimes the short-coupled variant of Torsade-Dupont. This paper from Andrew Marks's group was a case report, really, of a young woman who had short-coupled PVCs and polymorphic ventricular tachycardia. So did her mother, and they both shared a mutation in RYR2 that actually caused excessive calcium leak, but under non-stress conditions. And then Minoru Hori's group in Japan actually looked at a series of patients with short-coupled torsade. They found several with RYR2 variants, but only one that was clearly pathogenic. And that one actually was associated with reduced calcium release, so a so-called loss of function. So sort of the opposite molecular mechanism that we see in CPVT was associated with short-coupled torsade in that particular patient. A somewhat similar story was recently reported by Mike Ackerman's group in the Amish community. These homozygous duplications in RYR2, and the phenotype sounded a lot like CPVT. These patients were dying suddenly during exercise or during swimming, but when you exercise them on a treadmill, they really had no ectopy or mild ectopy. And arrhythmias that were captured actually looked more like short-coupled torsade, right? So just all of a sudden from sinus rhythm to polymorphic VT and then VF, not the typical progression that we see in CPVT. And a subsequent paper actually characterized the functional consequence of these duplications, and it was also a so-called loss of function or reduced calcium leak through RYR2. Now, one of the first papers that expanded the phenotype of RYR2 mutations was this one from Zahir Bouyan and Arthur Wild's group. And these were patients that actually had clinically recognizable CPVT, but they had much more severe sinus and AV node dysfunction. So it's probably hard to see this, but this patient at rest has complete atrial standstill and just a junctional rhythm. They also saw LV dysfunction and in some cases frank dilated cardiomyopathy associated with these variants. The other important piece of this was these were patients that had no mutations by standard sequencing techniques, and they only found a deletion in exon 3 by doing deletion duplication testing. And so this paper sort of highlighted the need to do that. And multiple groups have then documented this exon 3 deletion. It's a bit more common than we would necessarily think. So Minoru Hori's group in Japan, they re-examined their CPVT negative, or I should say their RYR2 negative patients with CPVT with deletion duplication analysis, and found 8 mutation carriers that carried that exon 3 deletion. And interestingly, in 7 of them, they had LV non-compaction, as shown here. And this figure is actually taken from this paper from Thomas Roston and Shu Sanatani's group, who identified a patient with sort of a mild version of CPVT, but also LV non-compaction. That patient had a mutation that was associated with so-called loss of function, again, reduced calcium leak through RYR2. And this paper, this is more recent. I think the final version is still in press. Also associating cardiomyopathy phenotype here, so pretty clear LV dilation and cardiomyopathy with really just a mild arrhythmia phenotype in a family with a premature truncation in RYR2. Now, one of the points I wanted to make today very clear is that you may have a patient with a odd phenotype and an RYR2 mutation, and it doesn't automatically mean that those two are connected. And we know that thanks to some important work by Andrew Landstrom and Jeff Kim and the group at Baylor that sort of gave us the background noise, if you will, in RYR2. So when they looked at over 150 patients with CPVT, they found rare variants in RYR2 in 60%, and that's not unexpected. But when they looked at patients referred for whole exome sequencing, this is over 6,500 patients, 9% of them actually carried a rare variant in RYR2. And of course, the overwhelming majority of these patients would not have CPVT. And of course, when you look in public databases like EXAC, the Exome Aggregation Consortium, over 60,000 individuals, 6% have rare variants in RYR2. So just because a patient's referred to you with a variant doesn't automatically mean disease. Even variants that we would think would definitely be pathogenic. So Wayne Chen's group actually generated a mouse model with that exon 3 deletion that was previously associated with disease in humans. And interestingly, although of course no homozygote mice were born because that would be complete loss of function, the heterozygotes had no CPVT phenotype. Okay, so here's ECGs from mice after epinephrine and caffeine injection, which would normally recapitulate the ventricular arrhythmias, and you can see just sinus tachycardia in the mutant mice, same as you see in wild type mice. And so presumably this is because the wild type RYR2 is predominantly expressed in these mice with reduced expression of the mutant. And so I certainly have seen patients referred to me with RYR2 deletions expecting them to have CPVT, and they've had no phenotype whatsoever. So again, phenotyping is very important here. So some of the non-cardiac phenotypes associated with RYR2, this was really interesting work published in JCI looking at endocrine consequences of RYR2 mutations. So this is a figure where they took CPVT patients who had RYR2 mutations and compared to age and BMI matched controls showed that they have abnormal oral glucose tolerance tests with reduced insulin secretion. And there's a lot more work in this paper that I'm not showing on the slide, but they showed pretty definitively that leaky RYR2 results in impaired insulin secretion. There's a couple of papers on some diseases that I'm less interested in, and they're in journals that I don't particularly read. So if you're interested in either of these syndromes, you can read these papers as well. And I think I'm right at 10 minutes, so I'll just quickly introduce this last slide here. This was a really fascinating paper that I would encourage you to read on your own time. This is looking at mice, a mouse model of Alzheimer's disease, and these mice have increased neuronal hyperactivity. But Wayne Chen's group actually crossed them with a mouse model carrying an RYR2 mutation that reduced RYR2 open time, and they showed normalization of that hyperactivity. And in measurements of memory, sort of mice working through a maze, they actually showed that they could increase memory in this mouse model of Alzheimer's disease. So there may be some therapeutic targets involving RYR2 for Alzheimer's disease, probably because RYR2 is highly expressed in the brain. So I think I'm over my 10-minute time limit, so I will go ahead and stop there, and I'll be happy to take any questions.
All right, thank you very much. That was a really interesting talk. Again, if you have any questions, please post those in the app so that we can ask those to our speakers.
And I think we have maybe a few minutes for questions. One question, Prince, this might relate the last two talks together, but in a patient without much other phenotype, but maybe had a sudden cardiac arrest, when you get an RYR2 variant, how do you treat the significance of that?
Yeah, no, that's a great question. So, clearly patients who've had an arrest, you want to get a good exercise treadmill test on them. And sometimes you can't do that in the immediate post-arrest period. And, you've got to sort of let them leave the hospital with a diagnosis of idiopathic VF. And so I actually typically don't start a beta blocker right away if I don't have a clear indication. And I'd like to bring those patients back once they're fully recovered and they can do a really good treadmill. If they have any ectopy at all on exercise and an RYR2 mutation and they've had an arrest, I would probably treat them like a CPVT patient and then put them on a beta blocker. Those who, they have a VUS and RYR2 and they've had an arrest, but I can get a really good treadmill, exercise them fully, and they have no ectopy at all, then I still consider that a variant that hasn't associated with disease. I won't necessarily put them on a beta blocker. Obviously, if they have recurrent VF, then I might reconsider that. But I'd have to say most of my idiopathic VF patients, that have left with the diagnosis of idiopathic VF have not recurred, and so I haven't had that occasion.
Okay, great, thank you. Well, I think let me see. It looks like there's no other questions listed at this time, so I think we'll move on. Thank you very much, Prince. Appreciate it.
Great, thank you.
So our next speaker is Dr. Elizabeth Stevenson. Dr. Stevenson went to Columbia for medical school. She did her residency fellowship and EP fellowship at Boston Children's. And she currently serves as a professor of pediatrics at University of Toronto and Toronto Sick Kids. And she's an expert on implantable cardiac devices and has authored many of the key papers on this in children and young adults. So I'd like to introduce Dr. Elizabeth Stevenson.
Thank you so much. I'm going to presume that everyone can see my slides and hear me, and just yell at me if I'm doing the classic not unmuted or something like that. And I'll try to speed through a big topic in a short amount of time. These are my disclosures. So first of all, when we want to think about ICDs in general, you want to sort of decide what exactly are you putting it in for. And ideally, you'd like to decrease mortality, but also minimize the morbidity. And we know that there's significant morbidity associated with these devices. In order to do that, there are two things that you need to do. The first is correctly identify those at risk of lethal arrhythmia, and we've been hearing about that in some of the other talks today. And what I'm going to focus on is the second one, which is choosing the best programming and hardware for your individual patient. So the subcutaneous ICD, just in case not everyone is familiar with it, is an ICD that sits outside of the thorax as compared to the transvenous ICD, where the generator sits in the axilla and the lead is tunneled across and up alongside the sternum. So there are advantages, and of course there are disadvantages to this type of system, and we're going to explore those a little bit. To begin with, all of these are really centered around the fact that there's no intravascular lead. So that gives protection against the biggest downside of the transvenous ICDs, which are the potentially devastating effects of an infection, which can lead to endocarditis and even death. However, it also leads to the major disadvantages of the device, which are that sensing can be compromised with both undersensing and oversensing, and that more energy is required to defibrillate when all of your voltage is traveling outside of the chest. That means you need a larger generator and you have a shorter battery longevity. This is what the device can look like in our smallest patients. And you can see that there's a tremendous amount of tension on the skin here. This is the first generation device, which is a bit bigger than the current generation, seen in a 32 kilogram child. Here's an example of some of the oversensing that's very frequently seen, unfortunately. And you can see here that into this patient's sinus rhythm, you have frequent T wave oversensing, ultimately leading to charging from the diagnosis of tachycardia and an inappropriate shock. Similarly, from the same paper, you see very concerning undersensing that can be seen. And this is an episode of VF that actually started about 2 seconds prior to this training, to this tracing. And you can see that there is lots of undersensing when the VF is more of a fine VF. The device does detect and start to charge here, but then again, it starts to undersense, and you have inappropriate markers missing the tachycardia, leading to a delay in shock. Thank goodness this patient eventually did get a shock, but it was quite delivered. So one of the things that we can do to help with this is to screen patients appropriately. And you can see here the screening tool that's used, and there are 3 different vectors: primary, secondary, and alternate. And you want to make sure that while you're screening, that your QRS and T-wave are fitting into the screening tool. It's also important to consider a post-exercise screen, particularly in our younger patients and those who we know can have very dynamic repolarization changes with exercise. So let's talk a little bit about the longevity. So on the left here, you see device longevity of the sub-Q ICD, and these are for device replacements purely for battery-based reasons. And there's censoring of any devices that were explanted for other reasons. This paper is a little bit more recent, 2019, looking at transvenous ICDs, but it actually looks back over the same time period. And you can see that, not surprisingly, those that pace more, the CRT devices, have the lowest battery life, followed by the dual chamber, and then the single chamber devices. And the comparison is with the sub-Q, an average of 5 years, compared to transvenous average of 7 years. And over the lifetime in our young patients, this adds up to quite a few generator changes, with the sub-Q requiring an average of 13 as opposed to the transvenous, which was 9. So that's a lot of extra surgeries you need to think about. Obviously, the sub-Q ICD is relatively new and is still improving, and we are seeing improvement in the generators. There was a great meta-analysis that looked at all of the small early sub-Q ICD studies that came out in 2018. And not surprisingly, they found that the lead complications were significantly lower in the sub-Q ICD population. However, interestingly, infectious complications were significantly higher in the transvenous ICD. And this probably has to do with a higher rate of dehiscence and erosion that are seen with the very large generator. And overall, for all-cause complications, there was no significant difference in these populations. I don't know if you guys can see my notifications, but I'm getting COVID notifications from my child's school as we talk. So we'll look at that when we're done. What a life. Okay, so we have great new evidence, which is really helpful. The Praetorian trials just released a few months ago, and this was quite a large non-blinded RCT looking at just over 400 sub-Q and just over 400 transvenous ICDs. It is industry funded and was published in New England Journal. So what they found was, not surprisingly, that in the transvenous ICDs, there was a higher risk of device-related complications, and that there was a lower risk in transvenous of inappropriate shocks. There was hope that with the newest generation of sub-Q ICDs, which have, they thought, better detection and better algorithm and better screening, that they would begin to approximate the transvenous ICD rates, but they actually still have a higher inappropriate shock rate. And when they looked at their primary composite endpoint, this was a non-inferiority trial, I should say, they did find that the subcutaneous ICD was in fact non-inferior to the transvenous ICD. And I think this reminds us that what we really need to be doing here is deciding which device is right for the individual patient in front of you. One of the things to think about is how large your patient is. So Pisano et al. In 2017 looked at their center experience. They had 12 patients who were between the ages of 15 and 29. And you can see there were 3 ARVC, 3 HCM, 5 with congenital heart disease, and 1 long QT patient. And of that group, 4 of them experienced device complications that required surgical intervention. And they were all around infection and erosion. And all 4 of those were quite small, with a BMI of less than 20. So that may be something that we should be looking for as a risk factor for people that are more likely to have device complications. Similarly, in the same year, Bettine et al. Looked at their sub-Q ICDs, and this is a nice paper for young people. They compared transvenous and sub-Q in an age-matched fashion. This graph is just looking at their sub-Q population, and what they found was that in these 31 patients, the inappropriate shocks were much, much more frequent in the younger patients. And we know this from our transvenous experience as well, that we see a higher rate of inappropriate shocks. But this is really quite impressive. And important to note that, like a lot of the sub-Q ICD papers, these are, the majority of these are inherited arrhythmia patients included. So this really is relevant to the group of patients that we're talking about now. So why do we care about these inappropriate shocks? Well, all shocks are bad. We know this, and we've known this for a while. In Scud-Heft, we saw that in a heart failure population, inappropriate shocks as well as appropriate shocks carried a mortality risk. The appropriate shocks, not so surprising, hazard ratio of 5.7. And with that, you know, this is a sicker group of patients, and so that's not very surprising. But interestingly, even the inappropriate shocks had a hazard ratio of almost 2. So this is not just an unpleasant event, but it has life implications. Similarly, the populations that we're talking about often have catecholamine-driven arrhythmias. And so they are at particularly high risk from inappropriate shocks, including potentially fatal electric storms in the CPVT population. Now, we've learned over the years that we really should try to avoid putting ICDs of any type into a CPVT patient, but sometimes you may not feel you have a choice. In that case, avoiding inappropriate shocks is absolutely essential. So that's one population to be very careful of. What else do we know about this specific population? Well, Conte et al. Looked at their large Brugada Syndrome group and compared it to some of their other channelopathies. So they had a slightly older group, 100 patients, 75% male, with a mean age of 46. 60% of their population was Brugada, and they compared against 20% LQT and 20% other inherited arrhythmias. They showed that they had a 13% screen failure overall, which is pretty similar to what's seen in the general sub-Q population, but it increased in the Brugada group to 18% and increased even more with Adrenaline. What they saw was that patients that passed the initial screen would then fail when they had those dynamic changes that we know Brugada patients can have either with Adrenaline or just at baseline with changes in both their QRS and their T-wave. So that's something to be quite careful of. What else do we know? Well, Rudick et al. Around the same time reviewed their own sub-Q ICD experience. And in this group, they had 40% Brugada, 27% IVF, 10 long QT, and 23 other. And they showed 20% appropriate shocks in 10 patients and 4 appropriate shocks in 2 patients, with relatively similar to transvenous rates. So overall, we can see that the subcutaneous ICD has matured to a point that it is non-inferior to the transvenous ICD, although anybody on the Heart Rhythm website would have seen that there is a new advisory for the subcutaneous ICD that just came out today. So we are still on the learning curve. You have to determine which device you need for your individual patient and consider your patient size, You need to screen them, including post-exercise. You need to think about the risk of post-shock bradycardia, which we didn't really talk about, but you cannot pace these patients, and whether or not they would benefit from ATP. Anyone who would benefit from ATP has a clear argument for a transvenous ICD. You need to think about the risk of inappropriate shocks in that particular patient. Thank you so much.
Okay, great. Thank you, Beth. We have a couple of questions. The first is getting an ICD effective? My dad was just diagnosed with Brugada Syndrome tonight, looking for answers to give him when I visit tomorrow.
It's a great question. I'm afraid I can't answer for your father because every case really does need to be considered individually, and so we would need to know a lot more about his condition. But typically, the rules around Brugada syndrome are that if someone appears to be extremely high risk, to have had a cardiac arrest or other very, very concerning event, it's often something that we would be discussing. They are very effective at treating malignant arrhythmias. So if you need one, they are a very effective device.
Okay, good, thank you. And then the second question is, what would you consider the smallest patient size where an SICD would be an appropriate choice?
Oh, that's a really tough one. I have to admit my own personal bias. I don't put in sub-Q ICDs, so I'm not the best person to answer this. But I have been impressed with the some of the skin erosions that have been seen and pocket problems in the smaller patients. So I think we do need to be quite careful. And absolutely, if you're putting it into a smaller patient, you need to be putting it in an inframuscular position in order to protect the skin a bit more. But I don't have an actual number that I would want to put to that. And I do think you have to look at the body habitus of the individual patient. A very, very thin patient is probably at higher risk of erosion and pocket complications.
Okay, great. Well, thank you very much. And I think we'll keep moving forward.
Thanks so much, everyone.
Okay, so it's my pleasure to introduce now Dr. John Skinner to give the next talk. Dr. Skinner is a consultant pediatric electrophysiologist at Sydney Children's Hospital, an honorary professor of pediatrics, child and youth health at the University of Auckland, and the head of the Cardiac Inherited Disease Group in New Zealand. He is internationally recognized for his work in heritable cardiovascular diseases predisposing to sudden death, and he will be speaking to us today about unexpected rapid monomorphic ventricular ectopy at peak exercise. Great, now what?
Well, thank you so much. I hope you can see my slides right there. This is a real honor for me to be talking at this meeting. I did wonder, this is a fabulous topic. I wondered why the organizers chose me for this. What we're talking about here is a very rare thing, seeing short coupled monomorphic ventricular ectopics on exercise. What do we do? I wondered whether it's just because, maybe I'm old, and, a truly unexpected finding isn't that common. So I have seen this a few times. So I want to share some case stories with you and then try and pull it all together with some conclusions at the end. So when I'm a bit lost in trying to find out about stuff in electrophysiology, I often go to Sami Viskin, a very wise cardiac electrophysiologist, and he's done some interesting work in short-coupled right ventricular ectopics here. This was a nice case series which kind of summarized the story. We see a lot of patients with right ventricular ectopics, which most of these are. They're usually benign, they get plentiful ectopy. They're often symptomatic palpitations, but they're very rarely malignant. They don't cause sudden death. And then there's another group which is much rarer, which causes idiopathic ventricular fibrillation or polymorphic ventricular tachycardia, like in Brugada syndrome. And they have very short coupled ventricular extras, not necessarily associated with exercise, typically not, in fact. And they present three cases here which are in the intermediate group. And there's an example of a 35-year-old woman with a very malignant looking VT starting up with a polymorphic VT with the ventricular extra. And what their conclusion was that malignant right ventricular outflow tract ectopy is characterized by a coupling interval of less than 390 milliseconds and the presence of an R wave on top of the T wave. So this is very uncommon in children, and to try to get a handle on this, I looked at a series here from New York. This is 1,000 or more exercise tests done in children. There's the standard indications. Most of them we do are for chest pain or palpitations. And clearly, if you've got malignant looking ectopy for that indication, that will be truly unexpected. They found, though, with 1,000 exercise tests that some sort of clinically significant arrhythmia was only found in 37, so about 0.3%. And increasing ventricular ectopy was one of those things, about 19 cases there. But when you look at those things which were associated with a malignant-looking arrhythmia, were these features down on table 4 at the bottom there: severe left ventricular dysfunction on echocardiogram, a pacemaker, history of an arrhythmia or an arrhythmic disorder, or non-sinus rhythm at baseline intervals. So those are the risk factors, and clearly this would make the findings more expected than unexpected. And one caveat here is that most of these tests were not done for family screening for cardiac arrests or for somebody who's had some definite arrhythmic syndrome. So really we need to focus on this word here, the unexpected feature. Now, of course, we should always expect the unexpected. That's our job. But in this case here, we've talked a bit about CPVT. The finding is expected. So this is an 8-year-old boy who had syncope riding on the bike. He was found on the ground beside his bike. And this is his exercise, clearly showing this bidirectional VT starting up down here. But CPVT has stages, as Prince alluded to earlier on. In the exercise test, one starts to see single monomorphic ventricular ectopy. And then this progresses sometimes to bidirectional VT, and then it can progress to VF. Now, the thing is that these ventricular ectopics are not typically short coupled, in fact. We know that they do occur occasionally, but mostly when one starts to see the starts to see ectopy in CPVT, it's not typically short coupled at peak exercise. Now, this does vary a lot, and a differential diagnosis in this sort of thing is Anderson-Tawil syndrome. They should have other features outside the heart, of course, but these patients tend to have a lot more ectopy at rest, as shown in those graphs on the right. Whereas CPVT, they typically have no ectopy at rest. See that red line there? And it's only during exercise that they start to get the ectopy. So clearly, when we start to see ectopy during exercise, we must be thinking about CPVT. So ventricular parameter beats in CPVT are usually left bundle, and they may not appear until 8 or 9 minutes into exercise, or indeed at peak exercise. Now, this is a case where it was truly unexpected. So this was a 13-year-old girl who came in with a very classical history of vasovagal syncope. And she had these ventricular ectopics on her ECG. The only reason this exercise test was done, because we wanted to reassure them that they could go through the exercise program to help treat the vasovagal problem. So this is a little triplet over there on the right, which looks quite worrying. But there was no family history. There was a normal echocardiogram and a normal cardiac MRI. And we went ahead and did cardiac genetics, really looking at RYR2, because of where that asterisk you can see there up at the top right of the screen, that looks a little bit bidirectional, and I found that quite worrying. But the genetic testing was uninformative. And in fact, after a 6-year follow-up on no medication, she remains very well. So here's another one, is a 14-year-old female with dreadful postural orthostatic tachycardia syndrome, and routine tests to reassure her for her exercise program revealed this. This was a Holter showing 3 fairly short coupled ventricular ectopics, certainly less than 390 milliseconds. And these 2 beats just in recovery there, at 1 minute. So what should we do with that? Well, of course, the first thing to do is check in detail the family history. And there was no family history. And of course, we do this properly. We draw a 3-generation pedigree, and we ask directly about each and every patient. The cardiac MRI and the echocardiogram were completely normal. And she couldn't take a beta blocker anyway because her blood pressure was so low, and she would not have tolerated it. And so what does this actually mean? Well, the other group that we're thinking about, of course, is this. This is a 12-year-old boy. Now, this was so dramatic. He came in with exercise-related syncope, and he was doing his exercise test. He lost consciousness, went flying off the back of the treadmill, and actually made a hole in the wall of the exercise test room. This was back at Green Lane Hospital. Now, we took him to the lab. He had a VT, which we ablated. And at age 30, he remains completely well. He's had no symptoms for 17 years. So this was not a familial condition. This was a focal right ventricular outflow tract tachycardia, which was cured. Here's a 19-year-old elite athlete who was undergoing a screening exercise test, as is very common in the States. And here we see a very rapid, monomorphic looking ventricular tachycardia. Now, no family history, repeat exercise test was completely normal, cardiac MRI was normal, underwent a full electrophysiology study, nothing found, had a reveal implanted, and he's now continuing his elite athletics. So how common is this? Well, this was a very revealing study from the Heart Rhythm Journal in 2015, which was a study reporting 5,000 consecutive athletes undergoing exercise testing. And what they found was that there were 36 athletes who had events like this on their exercise test. That's about 0.6%, and they were banned from sport, understandably. But in fact, 23 were, inverted commas, better by 1 year. In other words, their exercise test was normal at 1 year. 6 of them had an ablation, but there were no adverse events in the whole group during the follow-up. So presumably, therefore, these were not malignant. Here's a 12-year-old boy who I saw a couple of months ago here in Sydney with rapid palpitations during sport, feeling dizzy and short of breath, lasts up to a minute. And look at that. There he is 2 minutes into recovery in his exercise test, and he gets this very rapid monomorphic ventricular tachycardia. Now, he had a negative family history, a normal cardiac MRI, a negative EP study, and a rapid genetic testing for RYR2 was negative. So he's had a very good response to beta blockers. His repeat exercise test was normal. We're waiting and seeing, but he will probably come to the lab, and I suspect he's got one of those focal VTs like our other boy that I presented earlier on. Looking at things from the other side, because really what we're looking at here is a clinical test of uncertain significance. So one of the other conditions we're always thinking about in this scenario is arrhythmogenic right ventricular cardiomyopathy. And this was an interesting little report of 2 cases where they found that there was complete suppression of their ventricular premature beats at peak exercise. Now, typically we will use suppression of ventricular ectopy as a sign of this being a benign condition. But these 2 children both had ARVC, and yet their ectopy suppressed. So really emphasizing how this phenomenon is indeed a clinical test of uncertain significance. And I want to highlight this. This is a point made by Prince in his earlier talk, that ARVC can present without features of the cardiomyopathy. And PKP2 truncation variants are the classic scenario from Mike Ackerman's group here. Patients who presented with syncope or resuscitated sudden death had no features either on autopsy or on clinical evaluation of a cardiomyopathy, and yet had this mutation which is linked to ARVC. And we've seen this too in the sudden death series in Australia and New Zealand. So PKP2 tends to behave differently from other types of ARVC, and we need to think about that when we have autopsy or investigation negative cardiac arrest. Final case here is a 32-year-old man who presented to me some years ago with following a totally anomalous pulmonary venous drainage repair as an infant. He had symptomatic ventricular ectopy. He felt them. That was basically it. He'd had no syncope or anything like that. His investigation, as usual, has showed a bit of mild to moderate right ventricular dilatation, which we assumed was because he still had a right upper pulmonary vein connection to his SVC, which was left at the initial surgery. He was fit and well, productive office worker. Now, there we can see on his exercise that he's starting to get ectopy. And at peak exercise in stage 5, we're starting to get some quite short coupled runs of ventricular ectopy and non-sustained VT. So I took him to the lab and he had a grossly abnormal endocardial map and showing low voltage fractionated signals. He had several different ventricular ectopy from the right ventricular outflow tract. We ablated the dominant focus, but while we were discussing what to do about this, he had a cardiac arrest 2 weeks later. Thankfully, he was successfully resuscitated, but he in fact developed arrhythmogenic right ventricular cardiomyopathy over the next 10 years, which went on to affect his left ventricle as well. And he's now had a transplant and he's doing well. And I raise this issue here because of the unexpected word there. And one of my old American colleagues once said to me, you can have fleas and lice. So if you have one condition, it doesn't mean, of course, you can't have another one as well. So just to summarize all of this, unexpected, rapid, monomorphic ventricular ectopy on exercise. Great, now what? Pulling all of this together. The first question, is it truly unexpected? We need to really check the clinical history very carefully. Could it be familial? We need a full family history and consider investigating family members as well. We need to do a thorough clinical examination looking for features of desmosomal disease, such as curly hair, thick skin on the feet, or features of Anderson-Towel syndromes, for example, or skeletal myopathy, because that will change it. That will change the pre-test probability. So we now know, we're quite familiar with the concept of pre-test probability when it comes to genetic testing. We've seen this with RY/R2, we've talked about this before, that how you interpret a genetic variant depends on the phenotype. Well, here what we have now is a clinical test of uncertain significance, and its significance depends entirely on the pre-test probability. If there's a history of syncope, then finding monomorphic rapid ventricular ectopy is clearly totally different from if we have an elite athlete or somebody with vasovagal syncope who's where we have this finding. We need to do some thorough imaging. Could it be an early cardiomyopathy? We need to repeat the test. Consider doing a sprint test. This will sometimes manifest CPVT. And genetic testing, well, I'm not proposing that we should always do that in this situation at all. If we do end up doing it, then we should look at RY/R2 and PKP2. But I would urge a focused panel, don't do too many genes, because then we'll have a clinical test of uncertain significance combined with a genetic test of uncertain significance. And before you know it, you may have an ICD implanted for uncertain benefit. So it might be a focal right ventricular outflow tract tachycardia, which is manageable and ablatable. But with no clinical history and no family history, and all the tests are negative, this phenomenon is most likely not malignant. It might disappear, but of course, we need to follow this very carefully. Thank you very much.
Thank you very much. That was an excellent talk, and we appreciate your wisdom on this topic. There are some questions that have come through the app. I'll just, I think we have time for one. So one person has asked, how often do you reassess patients like this, and do you follow them throughout childhood?
Yes. I think, first of all, I would repeat the exercise test almost straight away, certainly within the next few weeks. And I would be following these annually. The things that I'm going to be following each time I see them, I'm going to be not just following their clinical progress, but I'm just going to be saying any new news from the family, anything else coming along. And if these changes persist on the exercise test, I may well go and ask one of my adult colleagues to look at the parents to see if they've got any features of disease with an MRI and exercise testing.
That's great. Thank you very much.
Thank you.
Okay. Well, we'll move back to the general session. So I'd like to welcome the allied health professionals back into the combined physicians allied professionals session. And as you're kind of seeing throughout all these talks, this is really a team sport, that taking care of patients with inherited arrhythmias requires all of us to come together around the patient, around the family. And with that in mind, I'd like to introduce the next talk on in establishing an inherited arrhythmia program. I'd like to introduce Dr. Stephanie Chandler. Dr. Chandler went to Case Western Reserve University Medical School. She did her residency and general pediatric cardiology fellowship at Boston Children's. She then did an EP fellowship at Boston Children's, and then she even did an inherited heart disease fellowship at Boston Children's. Since then, she has moved to Lurie Children's in Chicago and has Northwestern University, and has started up an inherited arrhythmia program. So with that, I'd like to introduce Dr. Stephanie Chandler.
Let's make sure that you guys can all see my slides. Can you all see that? Okay, great. First of all, thank you so much for having me. I have no disclosures to report. I've been asked to give a talk today on establishing an inherited arrhythmia program. To be quite honest, my first response when I saw the title was, I'm pretty much the wrong person to be giving this talk. All joking aside, my goal today isn't to pretend to offer the perspective nor feign the experience of other senior experts in the field, many of which we've just heard from. My goal is to offer the perspective of someone who's pretty green, who, much to the shock and chagrin of most people I know, decided after 7 years of medical training that a year of training dedicated to inherited arrhythmias would be very valuable. And finally, as someone who has been struck by fairly exquisite luck, both in my training and in my early attending life, by the chance to work alongside and learn from some of the incredible mentors in this field. So with that caveat, and given the short nature of the program, I'll focus on two main objectives. What do I think is the value of an inherited arrhythmia program? And what are some of the critical components of an inherited arrhythmia program? Inherited arrhythmia programs fall under a greater umbrella of cardiovascular genetics, along with a number of other disorders and syndromes, inherited arrhythmias, including long QT, CPVT, and unexplained sudden death, all under the recommendation of the American Heart Association, the American College of Cardiology, and the Heart Rhythm Society qualify for referral to a cardiovascular genetics program. When we consider specialist centers or inherited arrhythmia programs, the first logical question in my mind to ask is, why are they special? In the entire field of medicine, and particularly, for example, within cardiology, we have specialists within specialists. This is a growing theme in our field, and as both the breadth and depth of knowledge expands, we search for people who are sub-specialized. To that end, patients and families don't just want to see a provider who sees some patients with long QT. You want to see a provider whose practice is deeply dedicated to the care of patients with long QT and other forms of arrhythmia. So providers within an inherited arrhythmia program offer expertise and experience in the tasks listed here. Things like detailed phenotyping or understanding the physical manifestations of disease, genetic testing, risk stratification. As an example, why aren't all patients with long QT syndrome the same? And finally, in the screening and education of patients and their families. Funnily enough, it's not just those of us who work within these programs who think that these programs and having dedicated providers within these programs are important. In fact, these recommendations have been outlined in more than one scientific statement over the past 5 years by the American Heart Association. Not only is cardiovascular genetics a rapidly evolving subspecialty, as you've heard through many of the talks today, but we as practitioners are being charged, not unfairly, with trying to keep up with this burgeoning knowledge. And out of this comes an increased need for programs dedicated to the care of these patients specifically and their families. But how do you know that I'm not just blowing smoke? For years within the field of interventional EP, for example, we've known that having experienced and well-trained operators in the EP lab is associated with better outcomes and fewer complications. And we think that's also true in the care of patients with inherited heart disease. Sure enough, in a retrospective analysis published in 2016 out of a major center in Ontario, Adler and colleagues found that comprehensive genetic and clinical management in a specialized inherited arrhythmia clinic was associated with low mortality and low cardiac event rates. And this is just one example. I'll offer one personal example to highlight my fundamental belief that these programs provide expertise. One of the challenges facing providers in the wake of increased availability and usage of genetic testing is interpretation of those results, and specifically counseling families with pathogenic variants, but no phenotypic evidence of disease, AKA, I inherited the gene for hypertrophic cardiomyopathy, but my cardiac ultrasound is normal right now. How do we adjudicate this for families? In approximately my 4th month as an attending, a 9-year-old male was referred to me for a pathogenic variant in SCN5A, which was discovered as a secondary finding on his genetic testing, given a history of developmental delay, ADHD, and autism. His corrected QT at the time interval at the time was about 430 milliseconds, and there was no concerning family history. This is his high lead EKG, which is not perfectly normal, but didn't have some of the classic things that we look for when we think about Brugada. But as I sat down to look and review this case with my cardiovascular team here, we discussed the importance of anticipatory guidance for this family. When I finally met with this family and this child in clinic, his mother, being a nurse, came to clinic armed with very thoughtful and very poignant questions about literally all of the conditions shown here that she had come across during her reading. Sure enough, about 3 months later, this 9-year-old patient showed up in an outside ER with a fever of 104 in the setting of influenza and this EKG, a rather striking Brugada pattern that prompted transfer to our inpatient service for monitoring for the duration of his acute illness. And fortunately, he did well without any ventricular arrhythmias. But interestingly, his mother, who carries the same pathogenic variant as her son and affected with the same flu and a fever as her son, had an EKG performed at the same time, which was unchanged from her normal baseline ECG. I'm not sure that I, as a fresh attending, even with advanced training, might have been able to be so definitive in my recommendations to this family when I first met with them in clinic. But having discussed this case within our team, I, and therefore the family, had the benefit of multiple providers whose practice is dedicated to families just like this one. And this case, at least for me and my own practice, serves to highlight the next point, that one of the inherent benefits of these programs is that they often, you get more than one person, you get a whole team. As we move into the discussion of not just why we should establish these inherited arrhythmia programs, but delve further into the details, it's important to say outright that much like everything in medicine, there is no one way to do this. There's no magic recipe for building an inherited arrhythmia program. In both teams with which I've worked, the model looks like this on paper. As opposed to the more somewhat antiquated traditional hierarchy in medicine with an attending physician or surgeon at the top and a series of subordinate residents, fellows, and staff below, this model instead revolves around the idea of patient-centered care, with each team member having an important role in the care of the patient and the family. For me, the value of these teams can't be underscored enough, specifically as it has pertained to my own education. The number of things I've learned over the years, not just from other MDs with more experience than myself, but from our genetic counselors educating me about testing and life insurance, from a child psychologist imparting to me the wisdom of not lying to a child, even when we think that keeping the truth from them is the kinder thing to do, and from program coordinators who so often give us insight into these families before they even walk in the door for their clinical visit. Each member of these teams has an important role to play. And these teams perform optimally under the guiding force of thoughtful and experienced leaders whose focus both on the health of their patients and the health of their teams is paramount. Both of these two familiar faces will be quite mortified that I included this slide, but nevertheless, it underscores a hugely important point in my mind. My very wise mother used to tell me, people don't always remember what you say, but they'll always remember how you made them feel. And I think this doesn't just apply to our patients, this applies to our working care teams as well. When building a team like that of an inherited arrhythmia program, it's critical in my mind that these teams are led by those people who bring out the best in every member of their team, know their team members as individuals, and finally, whose actions and behaviors set the tone. They set the culture for the entire group. This conference is full of senior mentors just like these two. But for me personally, both as a trainee and as a junior attending, these are the individuals who lead by example and whose care, compassion, and expertise is transmitted both in the care of their patients and in the leadership of their teams. Finally, you can't discuss leadership without discussing culture. Culture is inextricably linked to an organization's performance and success. It varies across organizations, across industry, and across geography. So what works for us in Chicago may be different than what works for the group in Atlanta. A successful culture within one organization or at one time may not translate to others. And as such, I think it's important to understand that when building an inherited arrhythmia program, that one size doesn't fit all. I'm certainly not going to tell you there's a blueprint for building a successful program because we're still building ours. With that being said, I do think that one of the similarities across all successful inherited arrhythmia programs is the presence of strong and thoughtful leaders who cultivate a team of hardworking and curious members whose collective focus is on the delivery of excellent patient care, and fundamentally a group of people who both really enjoy the work and really enjoy working together. Lastly, I'll leave you with two final thoughts. Some groups have probably already mastered this, but one of the challenges that we have faced in our own team is the development of a family-centered visit, one in which both pediatric patients and their parents might be able to be evaluated. I don't think I need to underscore the importance of family-based screening to this group, but I do think finding ways to expedite and ease the screening process is critical for all of our programs. In closing, a rapid fire review. What's the value of an inherited arrhythmia program? Expertise, experience, and a team of providers focused on the care of patients with inherited heart disease. And what are some of the critical components when building these programs? There's no magic recipe, but good leadership and a focus on culture have time and time again proven to me to be of utmost importance. These are just some of my acknowledgements, and thank you for the opportunity.
Awesome. Well, thank you, Stephanie. And again, that really underscores the fact that this is it's a team sport. It takes a lot of people to really provide great care. With that in mind, actually, one of the questions that was asked on the app was, who are the key members of an inherited arrhythmia clinic? Question: genetic counselor, NP, PA, geneticists, bench researchers, psychology, etc.
Yeah, I think in every team, as I said, there's a slightly different and varied makeup. I think a genetic counselor is integral to all good programs. And I've been lucky to work with two exceptional ones in my career. But I think each team uses the resources that they have at their disposal and uses the team's sort of in the best way they can to provide the care that they can. Not everyone is going to be able to provide the same depth of care, have a psychologist, have great bench research. But that's one of the benefits of having programs like this, where you have a community of colleagues who can discuss cases, who can discuss these things when they come up, so that you're not ever really operating as an isolated group, but in fact, you're operating a little bit as a community.
Awesome. And I think we might have time for one more question. And this was, where does the general cardiologist or referring cardiologist fit in the care of inherited arrhythmias?
That's a great question. I think the best thing that we can say is they're an integral part, because they're probably one of the first people that see some of these patients walking through the door. And I think the relationships that you establish both in your own institutions and with outside and referring cardiologists is super important. So I think what I would say is, if you ever have a question or a concern and we can provide some expertise or even just have a conversation with you, pick up the phone and give us a call. That's how, all of us hope to operate, I think, always. And I think it provides the idea and the substrate for sort of the best care for patients going forward. They're sort of the door for us.
Excellent. Yeah, thank you very much. All right, well, we're going to move into the final session, which is a panel discussion. It's on the future of inherited arrhythmias. And so if attendees can switch into the WAHOVA app, and then the faculty are actually will be popping up in that talk in a second here.